MedBix Webcast is a new kind of healthcare media channel to break the silo mentality and foster interdisciplinary thinking. Our mission is to fill that gap and to create a curiosity through different lenses, tapping the passion that guided the historical figures in medicine and bringing present-day groundbreaking research to the front lines. We interview physicians and leaders in the industry about present-day healthcare challenges on our live programming.
Hey, welcome. This is Ramana Namalaju, MedBix, host of the MedBix Webcast. Yeah, I'm not Albert Einstein, but I'm pretty good. So that is a joke I do all the times, but you got to excuse me. No way I'm comparing the Albert Einstein to me, just a joke. So we have a very special program today. An old friend of mine and is a great friend and an excellent doctor. Is going to be on the program about talking about a metabolic complex and metabolic syndrome. You know, everybody is, now we are paying a lot of attention to the new thing is a metabolic syndrome and metabolic complexes. We'll ask him what is those stuff. And then after that, I'm going to present a topic on how the healthcare system should be governed. What is the fundamentals of the healthcare system we needed to make it work? It is just for all humanity, and I'm not just talking about American healthcare system. It's just for all humanity. Plato, Greek philosopher Plato, gave a wonderful wisdom to it. I'm going to talk about that, and then that is a topic. Let me bring our guest. Our guest is a very well distinguished guest. Is board certified in infectious diseases, and then he is a certification in obesity medicine. And then he has written several papers. I learned quite a bit from him about the metabolic complex and metabolic syndrome. Welcome, doctor. Let me bring him to the table. Welcome, Dr. Kamipelli. Welcome to the MedBix Webcast.
Thank you, Ramana. Thank you for reaching out, and it's a pleasure talking to you.
So tell me something about your background. Just I gave some background, but you can give me a little bit of expand your background a little bit.
So, I'm an infectious disease, wound care, and obesity medicine certified health professional practicing in Georgia. I'm originally from India, graduated in 95, I should say. Came to US in 97, did my infectious disease, and ended up doing wound care, and found out in 2015 that I was obese myself after 20 years of graduation, and figured out that the root cause of obesity and problems and my infectious disease patients that are going through trouble has a lot to do with the fat mass disease. So went ahead and became board certified in obesity, and also working on different projects, including some few telemedicine projects, and also was glad to be a part of a organization called Metabolic Health Practitioners Society for Metabolic Health Practitioners. So I'm here in Georgia trying to work with another colleague of mine targeting heart and vascular metabolic health, along with diabetic foot and obviously infectious disease services.
So you're talking about a metabolic syndrome, metabolic complex. What is a metabolic complex, Dr. Kamipalli?
So basically, it's a cluster of 5 conditions that are caused by chronically elevated insulin levels. I mean, this occurs when your organs fail, like say liver fails to respond to the insulin. So this can lead to heart attack, stroke, and problems associated with them almost 3 to 5 times normal when compared with the normal people. So this is very common. At least almost 50% of people have this, and we don't detect it. So let's come to the criteria. There's 5 of them. So take 5 fingers. You have like people with metabolic syndrome have 3 out of these 5. Okay, so it could be waist circumference. For men, it is 40 inches or more. For women, it is 35 inches or more. And also the second criteria is HDL, more than HDL, say less than 40 for
Can you
men.
repeat that, Doctor? What is 35 inches for men? 37 inches for men? What is
So
that?
basically, no, the
Waist
waist circumference.
what
The
is, yeah,
waist
how much it is?
for men 40 inches, and for women 35 inches. Anything more than that is you. So out of 5, you clock in 1.
Okay.
Okay. The second criteria is HDL, high density lipoprotein, one of the lipoprotein molecule. And basically in men, when it is less than 40, or in females more than 50. That is the second criteria. The third criteria is same for all men and women. It is triglycerides 150 or more. And then for blood pressure, all men and women, it's 130 by 85 is anything more than that. And also fasting blood sugar for all 100 milligrams per deciliter. So coming back to summarize it, 3 out of 5. So blood sugar more than 100, blood pressure more than 130 or 85, high triglycerides more than 150, and HDL criteria for men less than 40, for women less than 50, and waist circumference more than 40 for men, less than more than 35 for women. So 3 out of these 5 criteria, then you have metabolic syndrome.
Dr. Kambali, if you have out of 3 out of 5, that doesn't mean that you have a disease. You're not diabetic or you're not diseased, but it is an indication for the problems coming in the future. Is that right?
So it is a complex question, but it could be easily answered by understanding that there is conditions called pre-diabetes, there is conditions called pre-diabetes. So, let me help you understand that any disease like diabetes is defined when hemoglobin A1C is 6.5 or more, and pre-diabetes it is defined as hemoglobin A1C 5.7 to 6.5. You got that?
Yeah. Yes.
So,
Yes.
so basically, in this thing, we're talking about insulin. Insulin, which is a so root cause for all the metabolic syndrome is a hormone called insulin, which is associated with it is hyperinsulinemia. So for anyone to develop diabetes, that means the insulin levels are higher. Problem is your insulin level, you can have insulin levels higher for 10 years before you develop a disease. So the injury is happening already.
Already. So, Dr. Kambali, the primary care physicians, a lot of them don't pay attention to this kind of things until they become actually sick. Though they need to pay much more attention to the metabolic syndrome, metabolic complex, all the 5 indicators that you need to watch them as a primary care physicians at least. Do you agree with
So
that?
yeah, no, it's we read a lot of things in during medical training, but identifying and bringing see human mind is kind of very task oriented. So we are given a task. We have only 15 minutes, and all these criteria, the 5 criteria, have to be brought to the mind of the provider. So he has to take there is no dashboard that identifies that and brings it to the front of the physician and says, hey, this guy has metabolic syndrome, you need to focus on trying to figure out how to do help the patient. But the problem with providers is we have become a siloed thinking society, not the symphony of healthcare. So we professionals have specialized. Say, I'm an infectious disease doctor. I'm not an endocrinologist, so I specialize in one thing. So the healthcare has become a siloed thing. And if we say have a platform that artificially intelligent and identify these patients and bring them to the front of the provider, then the provider, health professional can diagnose and have that in front and then guide the patient.
So as you said that you need a dashboard. Dashboard would be excellent idea to see that five indicators, the status of the indicators that they look at it. One of the tests I used to do that is some autonomic function test, dysfunction test. That's one of the indicators. So I think all the five things that you look at it, I think it is a great idea as a dashboard for primary care physicians at least to watch the prevent these kind of things. Would you think that that is a good idea for the lot of primary care physicians to manage that kind of a dashboard?
So basically, it is easy. Number one, with new accountable care organizations that are coming up to try to create that platform for the professionals to be able to do that. Now, um, problem with aging and longevity is what where the healthcare is going. How can we keep people healthier and not toxic? So as the aging population is increasing, our obesity and all these problems are going to cause more trouble. So the health professionals need to be educated on prevention. If we don't understand and identify insulin resistance, which is the root cause of metabolic syndrome, we are all doomed. And we need to use technology, we need to use platform based solutions to prevent the complications of metabolic syndrome, which lead to non communicable diseases, which is the major important thing in healthcare right now. As a criteria, it is causing more problems than infections.
So lot of these so a lot of people think these are all something beyond my control. These are all genetic diseases, but as you're saying is different. You can control these five factors. Is under your control. Is that?
Yeah. So number one, the concept is about seed and soil. Okay, so you're born with your genes. Okay, and you have your bacteria, the food that you eat. So your genes and your genetic expression is depending upon the food and how your genes modify themselves to express themselves. So the more fat mass you carry, the more white cells go to the fat mass, cause inflammation, and then your body goes to repair the inflammation. It's like your lipoproteins are going there to heal the inflammation, and your body is trying to protect you. Whereas when you have too much fat mass accumulated, then that's a problem.
You say food is a medicine always, that is India. We all consider food as a medicine. Ayurveda says that food is an excellent medicine. So West forgot about that. The most of the Western medicine, they didn't pay attention to, you can eat anything keto diet, and then this keto diet, that diet, this diet. All these diets failed, continuously failed. What do you think? What do you suggest to that kind of situation?
So I would say real food is medicine. So not food is medicine. Let me correct you a little bit. Say real food is medicine. So food industry has hijacked us human beings. So I tell my patients this: there is a monkey mind sitting inside your mind. You need to tell that it has to sit in the corner, because we are dopamine driven beings. When we are living, we seek food and seek happiness, quick pleasure, not real happiness. We use food as a driver. So we have to engineer our environment. Now, coming to the dietary lifestyles, what is a different kind of diet? Mediterranean diet, or paleo diet, or keto diet. So what is the issues here is, in paleo diet, you eat more or vegetable based diet with little meat, whereas Mediterranean diet, you're eating fish and more like olive oil. So then the next thing is keto diet. What is a keto diet? Keto diet is a diet wherein you're harnessing your metabolism better. And with the keto diet, what happens is your insulin is stimulated less. So that is the so why is it called keto diet? Is it because your fat is harnessed out of your body in the method of making it ketones. That's why it's called as keto diet. So we can essentially have a full length discussion on keto diet, because I kind of support and empower my patients using that methodology of lifestyle in a safe manner, and I have helped people reverse diabetes, by the way.
Keto diet means what it consists of? What are the things that you can eat in keto
So,
diet?
so it's a spectrum, you see. So how can you define a keto diet? I don't really define keto diet. I call it therapeutic carbohydrate restriction, wherein we restrict your carbohydrate and optimize your fat intake so that you're burning your ketones. So people say they are on keto diet when they are eating different things, but it is a keto diet is when your ketones in the blood are in the range of zero point 0.5 to 3 millimoles per deciliter. You got it?
Um,
So blood ketones have to be zero point 0.5 millimoles per deciliter to 3 millimoles per deciliter. So that is a safe range of what is called as nutritional ketosis. That is, once we burn our fat, where does the fat go? Fat has to burn and it has to come out in the breath or in the urine or stay in the blood. So these are the only places in which fat, these are the only methods in which fat is going to burn. So there is no other way that you can burn fat. Fat has to come out as ketones. Now, when that range of nutritional ketosis of zero point 0.5 to 3 millimoles per deciliter is in the blood, then you are called nutritional ketosis. Whereas when it goes, say, to 5 or 7, or then when it reaches 10 millimoles per deciliter, then you are getting into ketoacidosis. Then that is what healthcare has confused this whole idea of ketoacidosis. One cannot develop ketoacidosis if they are making insulin and if their sugar is controlled. So basically, ketoacidosis is a wrong name, wherein it has to be hyperglycemic ketoacidosis. So so it's a complex topic. See, human mind, like I said, rationalizes and cannot take complex topics. And that is where healthcare has to learn, number one, grow, number two, give, number three. So,
Keto,
so
ketone. You can measure the ketone levels by blood testing.
oh yeah,
Okay.
and breath testing too, and urine testing. But most reliable is the blood. Second, I should say the breath, which I do every day, by the way.
When you're saying that that the keto diet is a broad spectrum, is it individually designed for each one, or
I mean,
is it
like depends upon what you want, what a person has to do. Or so how I design and treat is I do body composition of the patient. I sit down with the patient, spend time, and teach them, and then guide them, and then I give them an app. They take the pictures of the food. They take the pictures of their ketone reading, glucose reading, and then I sit with them and guide them, and I bring them back every 2 weeks, every 4 weeks, and then this I have done in people this with people who had bacteremia, who have fatty liver, who have diabetic foot ulcers, who had sepsis, and basically I reduce their fat mass, and they're amazingly better.
there is so much going on to talk about microbiomes. What is your idea about this? What the microbiomes play a role here?
So we are not
And
single cell.
explain what the microbiomes are first for the audience.
So basically, microbes. So I'm a doctor who's a bug killing doctor. It's like say, but then the question is, I have my website, nobadbugs.com. So why do I have that? In 2013 and 14, I was thinking, what am I doing with this whole antibiotic and using antibiotics to kill everything when we cannot completely kill any bug? Because number one, we are not who we think we are. We are bacteria with bacteria on our skin, in our mouth, in our gut, and we poop out things too. So we are in a cloud of bacteria. We are not. We are 90% gene wise. We are num. We have 90% bacteria. So we are a sack of bacteria that are walking around, and our genes interact with bacteria. So when we are eating good food, then our microbes are behaving good. When we are not eating good food, when we eat processed food or that causes hyperglycemia, glycemic spike, then the bacterial composition changes. Say there is some kind of bacteria called Bacteroides. There is some one kind of bacteria called Firmicutes in our gut. So if you're eating mostly carb-based food, then we get more of Firmicutes bacteria.
So
So
microbiomes is not just a bacteria, the fungi and the virus. They're all
yeah, yeah.
together combination,
It's,
right?
it's, it's called it's called virome or microbiome bacteria, and then each area bacteria is different.
Would
So
you ask the patients to or the primary care doctors to do the testing on the microbiome side and see that what is the levels and the new test coming up? Like a biome is, I interviewed a
yeah,
doctor,
I mean,
I
like,
interviewed a CEO of a biome. So is there any testing is useful? You think those testing?
so I mean, in people who have certain problems, there is a role for it, and I do think that needs guidance, that needs a lot of hand holding, and I think I've seen a lot of what Naveen Jain does, and he's very innovative. And the question is, um, there is a role if you if you package it with a program, but the program then has to be implemented, guided. So it's like you cannot throw a program at somebody and expect them to understand it, because even with what I do with my patients, it needs a lot of hand holding.
Yeah. So that I think what. So what is your treatment process for this? So the patients, what do you do? Give me a case of scenario, a case study. How do you go through the steps for them to maintain their health and the metabolic syndrome maintenance? Give me just a one case study, a quick
I mean,
study.
like, I have a lot of these case studies on my YouTube channel. If you guys are interested, I have a lot of them on the YouTube channel. It's on the bottom of my website. You can click it. Basically, um, there are people with bacteremia, I said, diabetic foot ulcers that I have treated with this. And there's a guy who has had diabetic foot ulcer with gangrene of the foot. So, so I'm an infectious disease doctor, wound care doctor, metabolic health doctor. So this guy needed all the three of my skills falling in place for him to heal. So it comes in with infection, with osteomyelitis of the foot, start him on IV antibiotic therapy. Then as I am working with him, I start talking about wound care, debridement, and taking tissue cultures. Then I do the foot offloading of the foot, and then help him take the pressure of the foot out, and then also then start talking to him about his. He was almost into dialysis, so I was able to prevent him from getting into further dialysis. I helped him lose his weight, and his foot is stable, healed, and he is doing great. And and by the way, he's off insulin. So what I'm trying to tell is that it is simple to easy to reverse this three simple process. Okay, eat less starches, grains, and sugars. Eat fat and protein that comes with fat. So protein, not the lean protein. I'm taking whatever fat that comes with the meat. Eat it. Don't throw it away. And then eat less often. Eat between, say, I tell my patients to eat in a 6 hour window, not even an 8 hour window, and avoid snacking. Cut carbs as much as possible and build some muscle.
What do you say? What is your advice on the intermittent fasting?
I advise them to eat. In fact, I do myself do intermittent fasting.
I do
So
quite a bit of
basically,
intermittent fasting. In fact, that's the only thing saving me. So you're saying that metabolic syndrome has to be maintained, but primary care physicians must focus a little bit on both the metabolic complex and metabolic syndrome. That's and then there must be some kind of a dashboard kind of thing. Then your procedural techniques and testing methods, procedural techniques to monitor all these five areas that you waist circumference, HDL, triglycerides, and then blood pressure and sugar. These are all five we have to be maintained, and then that's what your final analysis of that, if I understand you do.
so,
So, and the question I have is, a lot of people ask you, why, as an infectious diseases doctor, why do you get the obesity? Why do you get into all these other things? They see now, and now you mentioned about silo structure. Explain that, please.
so in role of there's a huge role of non-communicable diseases in infectious disease outcomes, like non-communicable disease like cardiovascular disease, diabetes, cancer are significant cause of morbidity and mortality across the world. And basically, um, uh, they say so 70% of the deaths by 2030. Okay, listen to this. 70% of the deaths worldwide is going to be because of non-communicable diseases, and they're talking about it costing around $47 trillion. Now, if you don't pay attention to that, then what else are we going to pay attention to? In 2009, WHO said that uh, non-infectious diseases are the major cause of morbidity and mortality. And also, say in Lancet in 2017, there was an article that was published that showed that high risk of severe infection and death from COVID is because this study analyzed, I think, around over 96,000 people, and found that diabetes is the highest risk for COVID. And also, there was some article in New England Journal in 2020 found that obesity increases the risk for it. So basically, what is a problem is the BMI. It's a BMI, but problem with BMI is it's a pseudo marker. It's not the real marker. So it's a crude marker, I should say. What we have to really look at is how infections happen is because of fat mass accumulation. We have to understand that. Now, you said primary care doctors, even specialists need to look at non-communicable diseases when the people are they come to you and you give antibiotics and you send them out and they're back again in 6 months later with another. I mean, like I was not able to prevent the revolving door of my clinic for the first, like say 12 years or so of my practice. Then once I flipped and I started talking about obesity and metabolic health, I think I'm able to make some dent in it.
You made an excellent case why there is a silo structure that's expensive. So I'm going to show you a video of the how why we need to raise the consciousness and why the doctors are needed. And this video explains very well that I made that video. Let me show you this video, and then
Quantum Physics for Doctors, Mystery Object in Medicine by Ramana Annamaraju. Dr. Champagne is a critical care physician and faculty member at Stony Brook University School of Medicine and a member of Pulmonary Critical Care Division. Dr. Pania is the prime investigator for a large study across multiple medical centers around the world about bringing people from cardiac arrest. Cardiac arrest is the arrest of pumping blood due to the malfunction of electrical activity in the heart. Cardiac arrest results in death within minutes without quick resuscitation. The resuscitation is the combination of procedural techniques of bringing someone from edges of death. One of those resuscitation techniques is a cardiopulmonary resuscitation, popularly known as CPR. Any delay administering in CPR, even for minutes, results in certain death. But there are certain exceptions and anomalies that raises several questions than answers in medicine and science.
34-year-old Audrey Mash went hiking with her husband on November 3rd when things took a turn for the worse. The couple got lost and Audrey went into cardiac arrest from severe hypothermia. But 6 hours after her heart stopped beating, doctors at Barcelona's Vall d'Hebron hospital were able to resuscitate her.
Amazing. It's like a miracle.
Audrey Schumann fully recovered and went back to her life as Audrey Schumann. Listen carefully what I said. She came back to life after dead for 6 hours as Audrey Schumann, not as a Margaret Thatcher, not as an African princess. Which one or what entity told her she is still Audrey Schumann? This is not some religious or a philosophical question. This is still under purview of scientific inquiry, particularly the process of cardiac arrest. Dr. Champagne is a prime investigator for the study called AWAKE, examines the process of dying and reviving. He conducted these studies in multiple medical centers around the world with reputable physicians with more than 2,000 subjects who went through cardiac arrest and successfully revived. Dr. Champagne argues there is a presence of some entity that is external to our world, beyond our space and time, reminding Audrey Schumann her identity. That entity is called consciousness. The study is a scientific odyssey of consciousness, the journey through an unknown worlds about some kind of a subjective awareness. Dr. Champagne had faced a resistance from scientific establishment without giving a due process and trying to sweep the studies under the carpet. The detractors' claim is the so-called consciousness has no place in the field of medicine. But Panya may have support from an entirely surprising field that is not so related to medicine, that is quantum cosmology. Andrei Linde, a well-known Russian-American professor of physics at Stanford University, gives a mathematical proof for the existence of consciousness. Linde was one of the authors of the theory of inflation. Professor Linde is a member of the National Academy of Sciences. When you apply quantum laws to the entire universe, the total energy of the universe must be equal to zero. If that is the case, nothing happened, nothing should happen, and nothing will happen in the entire history of universe. If everything is a zero-sum game, the act of you watching this video never happened, but the facts dispute, you know you're watching it. That is a scientific paradox. To solve this paradox, quantum cosmologists reluctantly injected an entity called a conscious observer. Your physical body is not excluded from the universe, but your consciousness is. Your mind became an observer. Now the entire energy of the universe can be equal to zero, your consciousness being the recorder of the history of the universe. Consciousness is the only way out to satisfy the mathematical equations of the universe. British professor of cognitive and computational neuroscience at the University of Sussex, England, argues there is only one thing there is. It is consciousness, and there is no evidence for anything else. But as a physician, you are wondering what is a patient's care is anything to do with the consciousness. But physician and the brain of a patient have one common purpose: keeping patient alive. You don't have to be smart to feel pain, just you need to be alive. Inside the brain, there are no lights, no sounds, no smells, and only electrical signals. We recognize and experience these signals through interpretations as a reality. It is certainly second person's perspective, mistaken for direct experiences.
A fake rubber hand is placed in front of them. Then both hands are simultaneously stroked with a paintbrush while the person stares at the fake hand. Now, for most people, after a while, this leads to the very uncanny sensation that the fake hand is in fact part of their body. And the idea is that the congruence between seeing touch and feeling touch on an object that looks like a hand and is roughly where a hand should be is enough evidence for the brain to make its best guess that the fake hand is in fact part of the body.
The famous rubber hand illusion and the extension of that one is with the magician David Blaine performing touch experiment with the actor Will Smith and his wife Jada Pinkett. In both experiments, Brain is wrongly guessing someone is poking them without being touched. Brain is clearly confused what is and what is not parts of its body. But brain has a bigger responsibility, keeping you alive. Sensory signals coming from inside the body are continuously telling the brain about its state of its internal organs, how the heart is doing, what the blood pressure is like, and so on. Patient perception is not just hysteria, it is a valid signal from the brain. Brain is a resident real-time monitoring system for keeping physiological variables within the bounds for its own survival. Anil Seth and his colleagues believe consciousness acts like a software platform for the biological interactions. Patient is not only a conscious observer of his or her own body, but also a particular participant. You can witness manifestation of consciousness in the doctor's waiting room, particularly if they are Medicare patients. In 1996, a group of people between the ages of 19 and 24 and a group of older people between the ages of 60 and 80 were asked to count out 3 minutes in their heads without watching the clock. The group between the ages of 19 and 24 clocked an almost perfect 3 minutes and 3 seconds of real time, but the older group did not stop until the staggering 3 minutes and 40 seconds. In a paper published recently by Duke University professor Adrian Bejan presents an argument based on the physics of a neural signal processing. He hypothesizes as we grow older, brain processing power is inversely proportional to the time in their mind. So older patients feel time is moving faster than real clock because their time scale is different in their conscious mind. As a physician, if you think there is only objective-based medicine, that's all there is. It is certainly a wrong conclusion. Next time, if you are walking by a patient on a life support system, show respect as they are conscious, reminding yourself Dr. Champagne's studies. Next time, before you dismiss a patient is hysterical, think of Dr. Anil Seth's studies that the patient's brain is the best patient monitoring system there is. If a Medicare patient complains he or she spends more time in waiting room than others, you realize Dr. Adrian Bejan's studies, patient's conscious time is different than clock on the wall. If you try to understand the conscious observer behind every patient, you see a great wonder and a mystery. You will become a perfect healer of body and mind. Computers cannot replace physician as such because the still unknown, still mysterious entity called consciousness is not computable. Only other conscious observer like you has the power to understand. This is Ramana Hannamaraju. Thank you for watching.
What I'm saying is why the telehealth is going to replace doctors, but why we need a doctor. My son told me a very interesting thing. He said that you can have all the paints next to you. You cannot paint a picture because you need an artist. So same thing, doctors to paint a great picture, you need a doctor to paint that picture, picture of health. So you are definitely part of that system. So, doctor, this is you gave an excellent education on the metabolic syndrome and the metabolic complex. This is a one area even the doctors not much aware of it. It's very surprisingly, and they are aware, but they're not taking because of the insurance system. The other aspects is really forbidding them to do a lot of things. So, what do you suggest to doctors to do? Do you have some plan for the doctors? In fact, Dr. Kamipalli, primary care doctors particularly or the patients can directly get in touch with you and talk with you about that, their metabolic, can you guide them to the process?
I mean, one person only can do so much in healthcare, you see, and it's creating people, process, and technology, and using technology to scale the solution and democratize healthcare. So, what I talk is what I talk, but at scale, things have to be done. And like you said, consciousness and being aware of what is happening, say, across the world is going to affect you. So, stuff happened in China, it affected all over the world. Stuff is, if say, if America sneezes, the world gets the cold. I mean, the question just comes down to, we have to, number one, as medical professionals, be the detective like Sherlock Holmes. You know, become a master listener and do it for passion, and treat the patient with empathy, with a whole patient approach, and pay attention to detail, and then take responsibility, because at the end of the day, you are the guy who is between the patient getting sick and getting better, and then pray, and then create. Just take ownership. Once you take ownership, everything gets solved because you own the problem. So that's what I do. I say, this is my problem, now I have to go and figure it out for each patient. So what I do is, I'm trying to figure out creating like people, process, and technology. I'm working with a platform of telemedicine solution. I've invested in telemedicine solution companies. I did not make a buck on it, but I still continue to believe, and entrepreneurial skills is a doctor mindset. So doctor can serve, but with, because a doctor cannot give up. So it's an entrepreneur in the doctor that has to harness their passion, create a purposeful life, and create some solutions with exponential thinking, and believe, because belief will make them achieve the solutions for one patient, but also patients across the world. Remember, I've in our previous discussion, I told you this whole thing that I talk about is because of one sentence that I wrote for myself. I'm going to create a self-sustaining healthcare system in India. And everything that I do, I'm in US, and I'm focused on trying to understand how I can drive down the cost and deliver things at scale in US so that I can replicate in India at cost zero to the patient, and which is what I will achieve.
As you said, that innovation is a center of all. I think, when the doctors trying to go that with a passion and a zeal to medical school, they have to use the same zeal and same passion to the innovation side. If
Yeah.
they tap that one, there's a lot of solutions will come out. That's what I say to the doctors when I
But
meet.
that is beaten out. That is beaten out of the doctor. Say, we work hard.
Yes.
It is beaten out because, number one, the reality of world strikes, the negativity comes into the field. And obviously, say, like right now, I'm talking to you, I took 1 hour of my time just because you called me this afternoon. I did not really, we did not plan this. You just said, hey, can you do this? And then I have 50 charts to do, and who is going to do it for me except me? And the
Yes.
whole day I'm sitting in talking to the patients and just writing some quick orders and pending the notes for doing some time. So it's like you're burning it at both ends, but I don't feel the burn. The reason why I don't feel the burn is, this is what you're meant to do.
Yeah. It is a big problem. Physician burnout is a big problem.
Yeah.
One of the things that, as you said, that you mentioned
It is a
just now.
burnout. It is a burnout. This is the wrong name, because when a purpose driven uh, doctor is doing things for the better of the patient, he will get immense energy. Now,
Correct.
if he is doing it for somebody else, not for himself, not for his patients, I mean, doctors go into medicine to serve. Now, if they are serving their patients, they will get immense energy. I can tell you that. But
You know,
when they are not serving the patient, then they're serving somebody else, and then all the negativity comes in.
Absolutely. Mother Teresa said that one time, I cannot touch a leopard for 1,000 pounds, but for the sake of God, I touch it. So the passion, spirituality, that's called Mother Teresa effect, actually. The spirituality, that passion that you have, If you touch that, you don't feel that kind of burnout. That's one of the very powerful things he said. Thank you, Dr. Kamipalli. It's truly an honor to talk with you. You gave education to all of us, and I took a busy away of time and then to educate all of us. Thank you so much. And next time when you come back, you can expand the wound a little bit on the wound care and a little bit talk about wound care. That would be next topic would be excellent idea for us. So as infectious disease doctor, we need to know a little bit of wound care. That is the second topic we'll do. Thank you. It's very truly an honor for me to have you as a great friend of mine. And thank you so much, sir. Bye-bye.
Bye.
We are retelling their stories through our patented designs that can be worn on scrubs, t-shirts, printed on conference bags, and endless other promotional materials. Daily Wear for Medicine is the first ever of its kind to create curiosity in medicine through visual art. We at MedBricks are celebrating unsung heroes of the past who made enormous contributions to the field of medicine through our unique campaign called Daily Wear for Medicine. You can wear it, carry it, and give it